Good morning everyone. Today I am going to teach you about PTH action, osteoporosis, osteomalacia, osteopetrosis, osteogenesis imperfecta and Pagets disease. I will tell you in detail about the PTH action and also an overview about all the diseases. What is the difference between each one, what is the main issue in each one and how to differentiate, how does it present and how to differentiate. This is mostly useful for students appearing for USMLE exams, and also if you want to know about what happens in all these diseases in general. First, let's see about the PTH mechanism on action. You know very well that PTH acts by activating the osteoclasts and thereby promoting the bone calcium reabsorption from the bone. But you need to know that PTH binds to osteoblasts and not osteoclasts. You heard it right. PTH binds to osteoblasts and not osteoclasts. So once when PTH bonds to osteoblasts, the rank ligand is expressed in the on the osteoblast. This rank ligand will this is the rank receptor. So this rank ligand will bind to the rank receptor on osteoclasts, thereby activating the osteoclast. The activated osteoclast will reabsorb the bone, thereby increasing the serum calcium. What about alkaline phosphatase? You should know only one thing, that is, when there is an increased osteoblastic activity, it causes an elevated alkaline phosphatase. That's all. Alkaline phosphatase rises with elevated PTH levels because PTH levels are going to increase the osteoblastic activity also. Or in conditions like Pagets disease of the bone, where there is abnormal turnover of osteoblastic and osteoclastic, whereby due to the increased osteoblastic activity, alkaline phosphatase rises. When there is a low serum alkaline phosphatase, it will indicate osteoblastic dysfunction because osteoblast is not functioning properly over there. Therefore, it results in low serum alkaline phosphatase. Let's start with osteoporosis. In osteoporosis, what is the definition? Here, the bone density is decreased. How much? When the bone density is more than 2.5 standard deviation below mean compared to young adult women, then that is osteoporosis. So in old age, that is bone densitometry should begin at age 65, then it should be followed up once in every 2 years. So the question might ask you to choose between female gender and age as the most important risk factor. In that case, we have to choose female gender. Similarly, if they ask you to choose between family history and age, then family history is the most important risk factor. Black race, which ethnicity is protective against osteoporosis? Black race is protective against osteoporosis. What is the cause for osteoporosis? Osteoporosis is caused by corticosteroids as well as Cushing syndrome. That is, steroids in general will result in osteoporosis. Cushing syndrome, there is excess production of steroids, so that will also result in osteoporosis. You should know that this idea of corticosteroids causing osteoporosis will be asked like a patient who's on rheumatoid arthritis and is taking steroids for a longer time, or any other disease where the treatment is steroids, and they might ask you what is he or she more prone to in future. So it is osteoporosis. Similarly, low BMI is another risk factor for osteoporosis. This is concentrated in step 2 CK. Inflammatory cytokines such as interleukin 1 is a trigger for osteoporosis. This interleukin 1 inflammatory, this knowledge will be tested like they will show you a highly trabecular or a hollowed out vertebral body. Then they will ask you what caused this. The answer is straight up interleukin 1. This is how this knowledge will be tested. How will they manifest? The manifestation will be compression fractures or the hallmark findings. Metatarsal stress fractures in young female runners is also due to osteoporosis. How will the lab findings? This is the most trickiest part. You should know that even though the bone density is abnormal, the blood serum calcium, phosphate, PTH as well as alkaline phosphatase are all within normal levels. What about the management? Weight bearing exercise is the first line management, followed by calcium and vitamin D supplementation. Weight bearing exercise is the first management, and that too outdoors are more important, more beneficial than pool exercises. Second line is the calcium vitamin D supplementation. After that, bisphosphonates can be tried. Teriparatide is an N-terminus PTH analog that stimulates the bone development. What about denosumab? Denosumab is a rank ligand monoclonal antibody that will inhibit osteoclast formation, thereby acting as a treatment for osteoporosis. What is osteomalacia and rickets? In osteomalacia and rickets, there is vitamin D deficiency. Osteomalacia is in adults and rickets is the pediatric equivalent. Vitamin D is necessary for the mineralization of osteoid matrix. That is, osteoid matrix is unmineralized. So, osteoid matrix has to be mineralized into hydroxyapatite crystals. So, for that mineralization, vitamin D is necessary. Fine. So rickets will present with craniotabes, rachitic rosary as well as genu and osteomalacia will present as a pseudo-fractures. What is pseudo-fracture? Pseudo-fracture is something like there won't be any fracture, but since there is no, the mineralization is impaired, there will, the bone, because of impaired mineralization, it will look as if it had undergone a fracture. So since it looks like a fracture, but there is no real fracture, it is known as a pseudo-fracture. Sometimes they might also give you in the vignette as non-displaced femoral head fractures. In that case, it also indicates a pseudo-fractures which is seen in osteomalacia. What is the etiology? Vitamin D is fat-soluble vitamin, isn't it? So for that to get absorbed, or for anything to get absorbed, we need a good GIT. So any malabsorptive diseases like cystic fibrosis or Crohn's disease will result in osteomalacia or rickets. Similarly, chronic pancreatitis, which is necessary for absorbing the fat and fat soluble vitamins, when that is impaired, as seen in chronic pancreatitis, that can also result in osteomalacia. What about renal failure? In renal failure, the final step of vitamin D activation, that is 1-alpha hydroxylase, 25 after 25 hydroxylation, 1,25 dihydroxycholecalciferol, which is done by the enzyme 1-alpha hydroxylase in the kidneys, that is impaired, resulting in osteomalacia. This is termed as the renal osteodystrophy. Fine. Okay. Now osteomalacia. Then they might give you a question like a 4-year-old male who has bowed tibias, and the question will ask for serum calcium, serum phosphate, PTH levels. Here vitamin D is abnormal, therefore the here the vitamin D is abnormal in osteomalacia, isn't it? So therefore vitamin D is necessary for calcium as well as phosphate absorption. So calcium and phosphate are also decreased. Parathyroid hormone, since calcium and phosphate are decreased, parathyroid hormone is increased. But in renal reasons, vitamin D is again abnormal, therefore calcium is not absorbed, but phosphate is increased. This is because the phosphate is not excreted by the kidneys, because the kidneys are in failure, that is renal failure. What is osteopetrosis? In osteopetrosis, there is an osteoclast dysfunction resulting in recurrent fractures in children due to bone density being too high. Since osteoclast is dysfunction, the bone density is high. You might be wondering, if the bone density is high, then why should it result in recurrent fractures? That's true, isn't it? But a normal bone strength is based on balanced internal architecture of the canals as well as networks, not just density alone. The second one is for the osteoclast differentiation, that is from the precursor osteoclast to form a mature osteoclast, you need granulocyte macrophage colony stimulating factor is necessary. So they might ask you what is that which is responsible for osteoclast differentiation, and in that case GM-CSF is necessary. What is a DD? Osteogenesis imperfecta and child abuse are the DD for osteopetrosis. What is osteogenesis imperfecta? Here there is abnormal type 1 collagen in the bones. The ossicles, that is the ear ossicles, are also made up of bones. So since there is an abnormal type 1 collagen in the ear ossicles too, it will also result in osteogenesis imperfecta. So there is the key differential feature is that you have to differentiate this from child abuse as well as osteopetrosis. Anyone with osteogenesis imperfecta will present with the blue sclera, but it is not always present. Maternal history of recurrent miscarriages may also provide a diagnostic clue. This is because when the bones are being formed in utero, they will undergo recurrent. The bones cannot withstand, and it will result in recurrent fractures, which will result in a recurrent in utero miscarriages. What about the Pagets disease? In Pagets disease, there is abnormal turnover. That is, there is mixed osteoblastic and osteoclastic phases, resulting in increased bone turnover. So, how does this present? Because of increased bone turnover, it will present with males over age 50 with enlarged cranium. Hat doesn't fit anymore. This is how it will present. And there will also be narrow acoustic foramina because of abnormal osteoclastic and osteoblastic activity, therefore resulting in tinnitus. Because of abnormal osteoblastic activity, there is isolated elevation of serum alkaline phosphatase. Here there is no other defect. The calcium is normal, the phosphate is normal, PTH is normal. There is only isolated elevation of serum ALP. Because the bone is undergoing abnormal turnover, it will result in intraosseous AV fistula, leading to high output cardiac failure, S3 heart sound, and a high ejection fraction. This is my last slide. I want to tell you that if what is the most important predictor for successful rehabilitation? Anyone with a femoral fracture, they might ask you, what is an important predictor for successful rehabilitation? Excuse me. That is pre-fracture activity level. So high pre-fracture physical activity will correlate with better bone density and improved recovery outcomes. With this, we have come to the end of our lecture. I have an announcement for you. I am starting my mentoring lessons for USMLE. If you like my videos and if you like to get mentored by me system wise or 2 or 3 systems together, either one-on-one or in group, feel free to reach out to me. Looking forward to see you succeed. Have a good day.